Thank you. So we'll be two for presenting, but my colleagues are in the room here, so they'll be available if you have questions also. So I'm really pleased to present you the GenderARP project, which is a project on addiction, health, and recovery in context of social precarity, how to better address complex needs, taking into account gender and life stages is the title of this project. So I thank also all the team for the presentation, and the doctoral students also were implicated in the presentation. So as a background, maybe we can remind that the influence of gender on psychoactive substance is still poorly documented. The programs and services that are implemented and evaluated in this field are largely unsuited for gender issues, and it can even contribute to or even accentuate certain inequities. So our project aims to better understand how gender and life stages influence addiction, health risk, and recovery trajectories in order to guide the development of integrated services that address complex social and healthcare needs. So maybe some words about the team. So it's small, but maybe I cannot identify everybody in the teams, but I want to highlight that we have interdisciplinary teams. Myself, I'm a psychologist, Marie is a sociologist, and André is from the criminology field. We also have public health doctors also in the team. We have expertise also in the LGBT, with LGBT communities, all the diversity, sexual orientation, and gender diversity, how it intersects, for example, with gender. And also some colleagues from oui, so voilà, you will see, thank you. So you see the name, but with all these disciplines, and about some different kind of gender expertise. So a lot of interesting discussion between the member of our teams. We had the chance just before the COVID in December 2019 to meet and to talk about the theoretical and methodological issues of this project. So I thank the international teams, and I want also to underline the huge work doing by the PhD students. We have 9 PhD students who integrate their doctoral project within this project also. And we work with, it's a collaborative research project, so we have harm reduction and addiction treatment, as well as LGBTQ community partners who work in the 3 countries in collaboration. So we had the chance to meet in presence, and physical presence, and virtually a few times during the project. So we have also a provincial or a national association with many type of services in the association who facilitate the analysis and the way we think the project, and also concretely the data collection also. So we have a descriptive, interpretative, qualitative design guided by a collaborative approach, as I stated. We led semi-structured interviews based on a life course perspective. Voila, merci. That's no, it's, maybe no, it's okay because I have 2 screens. I thought it was a good idea, but I think my brain is a little bit on the décalage horaire. Alors, sorry about that. So sorry about the diapo. So for the semi-structured interview based on life course perspective, we try to understand the perspective on the concern of the person who used substance, about their recovery trajectories, and to understand the influence of gender using their own perspective. So the sample diversification was based on age, gender, sexual orientation, and also gender diversity, profile of substance use, and type of services that they did, so harm reduction or treatment or no treatment at all. In Canada, mostly in Quebec, we have 76 participants who did the interviews, and we still have data collection with the new doctoral students that is more on the people with diversity of gender, trans people or non-binary, for example. In France, we continue also the study, but we have 50 participants and 8 focus groups with 15 women identified themselves as militant feminists. and the data collection is still undergoing for some of, for in Bordeaux and Guyane, for example. We have in Belgium 39 participants and still going also in the data collection. In Flanders, we have some new data collection in the Flanders part of Belgium because of the collaboration we have with Wouter van der Pleschen and in his team at Ghent University, focusing about the LGBTQ community and also parents for the parentality issues in gender related to gender and substance use. So we did thematic analysis guided by an intersectional perspective, but also the gender transformative health promotion framework from Peterson. We looked during the life course how the different social dimension related to health, the political, for example, the systemic barriers can influence also their trajectory. So we, for example, how they feel stigmatized, the type of barriers they encounter when they use services, how the social norms influence the way they use substance use, for example, was themes that was explored in the interview. So we try also to see how the services they use were maybe perpetuate gender inequalities or blind, so don't consider the specific needs, for example, going to gender transformative with some services rare, but we see some services who are more gender transformative. We try to analyze the barriers and to reduce actively the causes of gender-based health inequalities in their service organization and practices, for example, and try with all the partners involved to see how we can go to enhance the services, transforming, taking into account gender, these services. So some key results from Canada, just some examples because we have not enough times. For example, we look at, with the participant at substance use and gender norms. Women in the sample, for example, talk a lot about the representation of being a woman in our society. What is it? They talk about high standards, pressure about physical appearance, the role of mother being really seen as a pressure, and all the tasks they feel they have are the responsibilities related to the task, that it's high standards and pressure that was really difficult to live with. When they talk about this pressure, they explain that the substance use can be a self-medication to try to diminish the psychological distress related to this high pressure, for example, or sometimes even to have a good performance over these norms. So the second transcription, for example, the woman explained that she took cocaine to perform and to succeed in realizing all these pressure. So to deal with this pressure and succeed. So another aspect is the negative view of women who use drugs. So it mainly the majority of women in this sample find that, for example, here the sample, the transcription, sorry, she said women are looked down on a little bit more. Especially mothers are more pointing of fingers. Whoop. Voila. You see the diapo like that. Another aspect is representation of being a woman is associated of the risk of getting assaulted. Majority of the women in the sample also was victimized at one point in their life. They explain how, for example, their clothes will be adjusted to be like in a defensive position. Here, a woman explained that she put steel-toed boots, for example, that if anyone attacks her, then she'll be ready. So there's some aspect related to their look, for example, sometimes to try to prevent being attacked, for example. And the second transcription, we see that the substance use in the social context is associated to this perception of high risk of being assaulted. So for them, the relation with being a risk of being a victim again when they take substance use is really present in their trajectory. We look also, I'll put just some result, but for example, here with men in their sample, we ask them a question about masculinity and femininity, and they explain, many heterosexual men, for example, explain that substance use is part of their identity and the masculinity, how they represent masculinity in the society. So this participant explained, for example, that he's in the electronic music industry, that he gets approval and respect also, and okay, sorry, so he get approval and respect in this particular context, and that selling drugs, for example, is one aspect of his role that is seeing like having power and even being seductive, sexy for the woman. So that was often the case in men, but not in women, the power that being related to substance use and even selling drugs can give power to them. Okay, if we look at the pathway barriers, in the care pathway barriers related to gender, for example, women report multiple barriers like shame, lack of resources specific for women, the mixed gender services that is found difficult, lack of respect and judgmental attitude, also in the context of care, and the obstacle to the involvement of loved ones, for example, couples or children that are not accepted in the treatment. Another aspect, for example, as an illustration, in the mixed gender services, why it's found difficult for many women, they explain that they need a safe space to discuss sensitive topics such as trauma, who are really prevalent in this population, and also the relational issues, for example, the seduction, emotional dependence, the power issues in the relation that are seen as an obstacle to a recovery. So for many women, because they don't find specific woman treatment, they will choose after a negative experience, feeling judged or stigmatized in this type of services. They just don't go in services after. We see, I find it ridiculous. It's a woman who feel really difficult this experience and don't want to go in treatment again. So the masculinity and substance use, we have some specific barriers to help seeking too. Men explain that this power associated with substance use, there's like an incoherence when they want to ask for help. So they explain in this transcription, for example, that cocaine, for example, specifically, is related again to being to ego and pride, and to have to be seen socially as someone who has power. So to accept that they have an addiction and go ask for help, display their vulnerability is really hard for many men. That's something that is repeated in the discourses. Rapidly, some key results from Belgium. The analyses are undergoing also. We see that violence and victimization over the life course, there's a doctoral student who works specifically about violence and victimization and the complex interrelation with substance use and the relational power dynamics. And she see that it's really integrated to treatment approaches, even if it's really integrated in their life course. When they discuss access to services, the failure to accommodate obligation related to parenthood and employment for women, for example, and the lack of provision of services to couples are identified as barriers, in particular for women. The service provision is seen often satisfactory with regard to substance use, but they should be more comprehensive and take better into account the diversity of needs, like violence, trauma. It's not really taken into account in the services. So Marie will present some key results from France and also the conclusion, the impact of this project.
Thank you, Karine. So thank you, Karine, for giving me the opportunity to present some specific results from France. So in France, we also have results that are quite similar to what Karine presented for Quebec, but we have also some specificities due to the methodologies that we used. So in France, we decided to begin with a focus group that we implemented with feminist activist group in Marseille, and it gave a specific framework. So this framework is, this theoretical framework is a feminist approach. And this feminist approach argues that relationships to drugs are linked to political and social systems and are subject to social relations of gender and oppression that need to be explored in order to go beyond an approach focused only on biological vulnerability. And women who are presented as vulnerable also possess individual resources, deploy risk reduction strategy, and have a capacity to take action. And for this feminist group we work with, it was very important to give a representation of women who use drugs not only as vulnerable persons, but also as active women that empower themselves by participating to this feminist group. And these women reclaim their stories through a narco-feminist approach that we decided to use in this project. This narco-feminist approach is also called auto-ethnography, and this auto-ethnography denounces relations of oppression, produces new subjectivities, and invents new forms of resistance to discrimination. So during the focus groups, the women described avoiding individual contact with health professionals so as not to endure discourses about women who use drugs that often oscillate between infantilization and false benevolence, as you can see in this quote. So the women that that participate to the focus group find that a holistic approach that considers both mental health and drug use is very difficult to obtain. And they describe also the world of psychiatry as a world that tends to stigmatize them, and they don't feel taken into consideration. So based on the focus group results, these women are building a collective story that we use for the GenderARP project. And this collective story is situated within logics of empowerment, with the idea that disclosing experience of drug phobia in written form can make representation evolve. So during the focus groups, they say that society should work on representation, while users, and especially women, are systematically put in a position where they have to justify themselves to apologize for drug use. And these guilt-inducing representations are particularly significant for women and can lead people who use substances not to ask for help or to hide certain drug use practices, and thus to hide a part of who they are, and they are less well supported due to this stigma. So I will now present some key messages from the 3 countries. So our research underscores how gender inequal services perpetuate gender inequalities. We highlighted that experiences of stigmatization or lack of safety in the context of care, difficulties in access to adapted services block help seeking or contribute to discontinuation of service use, especially for women. Accumulation of stigmatized identities accentuate barriers to care, and transformative services are rarely reported but have a significant impact on the recovery pathways of women. And unfortunately, these services still tend to focus only on mothers. And women might also benefit from group work aimed at empowerment to acquire skills to address the difficulties they face and overcome barriers in access to care and prevention. So the collective stories of empowerment enable women to restore their capacities to take action, but we also need profound structural changes, and especially the implementation of gender transformative services that Karine presented just before. And we also need a move towards less discriminating representations of people who use drugs in our society. So I will now move very briefly to the expected socio-economic impact of our project, and I will synthesize. So GenderARP mobilize stakeholders in the transformation of addiction services from a gender perspective. We use the participatory-based approach, and we hope that this approach will improve access to addiction treatment and harm reduction services, and that our project will enhance quality of care, and that it will contribute to diminish the high socio-economic cost of problematic substance use. We also hope that our project will reduce the stigmatization of people who use substances, in particular certain subgroups more markedly affected by stigmas, such as women and sexually and gender diverse people, and we hope that it will contribute to reduce social inequalities in health. So regarding knowledge mobilization and impact of research, so we have about 10 scientific publications, and for the number of presentations, it's huge, and I don't have the exact number now. We also have 9 doctoral theses that have been conducted for the GenderARP project, external scholarship awards, international research internship, and gender training. So GenderARP also give us opportunity to provide leverage to obtain further funding. For example, Karine was successful and got a CIHR research chair in gender and intervention in addiction in Quebec. And myself got also large grant from IRESP, Institut de Recherche en Santé Publique, that allow me to implement the network D3S at EHESS, the Advanced School for Social Science, with a focus on gender and participatory research, and Karine is also one of the coordinators of this network. We also got COVID-19 rapid response grant in Quebec and in France, and as a result, we also published a paper in criminology that compare France and Quebec. We organized 3 international conferences with partners and people who have lived experience, 2 in Paris and 1 in Quebec. And we have also online dissemination of webinars that highlight especially the work of young researchers. We also wrote several articles in professional and scientific journals that have been co-written with people who have lived experience, because our project is embedded in a participatory research. And the NGOs who work with us have also the opportunity to develop their own project with the GenderARP project. So, for example, l'ETP, the French feminist group, decided to produce a fanzine, a writing workshop with the money of GenderARP. And in Quebec, we have also several projects, Les Chroniques de l'Invisible, which is an online participatory media project, and Les Ateliers de Dialogue, a webinar series for practitioners and researchers to share experiential and academic knowledge. And to conclude, here are the direction for future research, and you can see that we have still a lot to do together. So thanks for your attention.